Last class we finished with the discussion of actually skin anatomy, and now it's time for the fun stuff, which means we're going to talk about diseases and different pathogenic conditions of the skin. One that is pretty common is eczema. You can see, those of you who suffered from it knows how unpleasant it is. Skin becomes dry, skin becomes flaky, skin becomes cracked. Sometimes it gets as far as to bleeding the skin. There are two major causes. One is overwashing, just dry skin. Can be treated with moisturizers. And another, it's allergic response or any other sort of autoimmune condition, because essentially allergy is the immunopathology. It's the immune response to things that you're not supposed to develop immune response to. Can become chronic. In case of allergic response or any type of mild autoimmune response, corticosteroids and other immunosuppressants prescribed, usually not oral. In case of eczema, it's usually topical corticosteroids, although you have to appreciate, in case of eczema being an autoimmune reaction, when we use corticosteroids and suppress local inflammation, we are not treating the cause. We're treating the symptoms. And, for instance, if you have eczema and you use topical corticosteroids for, a couple of weeks, it goes away, you stop using them, eventually it will come back. So pretty much you're kind of bound to use them on and off. Many pathological conditions of the skin are linked to the abnormal, bacterial infection. Okay, I'm not talking about viral here yet. If you want, I can kind of mention them on pause. Those ones that you need to know, I will ask you about. Two major microbes that cause skin pathologies are Staphylococcus aureus, the infamous microbe that I bet everybody heard of, and Streptococcus pyogenes. Streptococcus pyogenes is a microbe that can also cause strep throat. These two microbial species, first and foremost, are notable for the ability to cause the condition known as impetigo. You can see the photograph of a child with impetigo here on the right. Now, it looks very unpleasant. Interestingly enough, those lesions that you can see, they are usually painless, maybe mild itching. The main risks associated with impetigo, if the microbe migrates deeper into the skin, in the dermis, or in a subcutaneous layer. That can be a problem. Also, obviously, these wounds, these lesions, are more prone to the secondary bacterial infections. Impetigo is highly contagious by contact. It usually affects children, at the age of 7, 8, 9, when they start playing contact sports. If you have one child with impetigo on the football team, the entire football team is going to have this disease. I can vouch for that. I've seen that. The entire football team had it, over the span of 2 months. Erysipelas is an infection of an immediate subcutaneous tissue, adipose tissue, usually with Streptococcus pyogenes. You can see the areas here with erysipelas. They are red, look inflamed, warm, tender, The treatment for both conditions are antibiotics. For impetigo, usually topical antibiotics will suffice. For erysipelas, the patient has to take antibiotics by mouth. Now, the condition that looks a little scarier than that is a scalded skin syndrome caused by Staphylococcus aureus. In this case, epidermal layer of the skin, you can see this on the picture, starts to slow off. This condition is fairly common in newborns, can be treated with antibiotics quite effectively. The main complication of scalded skin syndrome is secondary infections. When dermis becomes exposed, the risk of infection of the dermis, infection of subcutaneous tissue is much higher. All infections of the skin, bacterial infections of the skin, the major threat, which is, I'll be honest, it's very rare. The major threat is the condition. I didn't put it here because it's not technically a skin condition. It's called necrotizing fasciitis. Sounds pretty scary, and it is scary. It's the bacterial infection of connective tissue that lies deep under the skin. If you've ever heard about flesh-eating bacteria, that's it. This condition is actually life-threatening. It's very hard to treat. Often results in amputation or surgical removal of affected tissue. It's pretty nasty.
This can cause that?
If it goes for a long time, bacteria can, and if patient is immunosuppressed, bacteria can migrate from the skin deeper into the tissue, and infection of connective tissue is the whole different ballgame. Speaking of scalded skin syndrome, the mechanism of the disease is quite fascinating. Staphylococcus aureus produces so-called exfoliating toxin, enzyme, protease, that breaks down proteins. Let me go back for a second and remind you what our skin looks like. It has superficial epidermal layer, right? And deeper dermis. Any epidermal layer, any epithelial tissue, what is it attached to? The bottom. What is it attached to? The basement membrane. That protease breaks down basement membrane. And when basement membrane is gone, obviously epidermis and dermis will become separated. Does that make sense? Okay. Not for exam if anyone interested. Warts, virus infection caused by papillomavirus. They are not preventable. They are not curable. The only way to get rid of them is with laser. Don't do liquid nitrogen. Long, painful, ineffective. Now, cancer. So, generally, the malignancies of epithelial tissues called carcinoma. Okay, make sense? So, malignancies of the skin, the most common malignancies, they arise in the epithelial tissue, the epithelial part of the skin and the epidermis. Before we move on, what is cancer? Yes.
You have an overgrowth of cells, they're just out of control.
Why are they out of control? What they don't do?
They don't die.
Excellent. They don't die.
They didn't replicate correctly DNA.
Yes. And accumulate what? What do they accumulate? If they don't replicate correctly, if their DNA is not copied correctly. What's the word for mistakes in DNA? Mutations. Accumulate mutations. That makes sense? So every cell, and that's one of the sort of fundamental things to know in terms of cell biology. Every cell has the life limit, right? Every cell dies. How do we call normal cell death? Anyone knows? Apoptosis. Yes. So, tumor cells, they lack proper apoptosis signals. They don't die. Does that make sense to you? To give you a perspective on cancer, every time the cell replicates, about 3 mutations are introduced. The more cells divide, the more mutations are there, the more chances someone has to develop cancer. I wanted to say something and I totally forgot what I wanted to say. Well, cancer is pretty much inevitable. We become older, we have more and more chances to develop cancer because cells replicate more and more. I can tell you something else. I had a conversation with a doctor who is head and neck cancer specialist. And according to this doc, every time, like every given second of our life, we have 1 to 2 tumors in the body. They do not become full-fledged tumors. They just start. And the immune system shuts them down. Well, sometimes people get unlucky and tumors grow, and that's what we call cancer or production. My regular plug for the course, it's not shameless plug, I'm not plugging anything that I wrote or I created. If you are interested in medicine, if you are interested in cancer biology, I strongly recommend to get the book called The Emperor of All Maladies. It is the history of cancer, written by the cancer biologist named Siddhartha Mukherjee. He's a physician and scientist at the Harvard Medical School. It's a pretty big book. It's not an easy read. I mean, it's like, you have to think. I couldn't put it away. It's just absolutely fascinating. It's pretty grim. Nothing optimistic about cancer. Okay? But I strongly recommend this book. Really. He's a great author. He's a great language. He knows how to write. And he writes absolutely captivating stories. I believe you can get it for maybe a few bucks on eBay. And you probably can get it at a local library. I don't think so. No. I mean, I doubt it. Yes. Malady, Mukherjee. It really, he has a couple more books, and I can tell you, I got one of his later books, The Gene, the Intimate History of Molecular Biology. I got it for my kids, not hoping that they're going to read it. They loved it. They said it's a great book. It's hard to read, and they churn through it slowly, but they just love it. Okay, so I recommend it, highly recommend it. So, cancers of the skin. There are 3 major types that I'm going to ask you about, and one very rare type that I'm not going to ask you about. The most benign, if I may say so, type of the skin cancer is called basal cell carcinoma. It's also the most common. it looks like the enlarged elevation, the bump on the skin with a depression in the middle. Usually can be found in the face, nose, chin. It originates in the basal layer of the epidermis, stratum basale, and can be fairly easily surgically removed. Usually there's no need in chemotherapy. And survival, I mean, I personally know a woman who had basal cell carcinoma, and it was sort of, okay, I went to the doc, they removed it. That's it. So, I mean, I'm not saying that it's something you can shrug off, but it's very easily treated. Squamous cell carcinoma. Lip, scalp, ears. Usually it's the ulcer, so it's not elevated above the level of the skin, quite opposite. It is depression, it's the ulcer, with elevated edges, and this is more invasive type of cancer. It may metastasize. The key to the successful treatment is the early removal. Speaking of metastasis, what is that? It's pretty much cancer cells can detach from the original tumor, end up in the bloodstream, migrate to other organ, and start growing in other organ. And you can imagine that treating metastasis much harder, because at the moment when cancer starts to metastasize, you don't really know where it is. You know, if you find metastasis, it's hard. Some organs are harder to reach by chemotherapy. You know, for instance, like in the breast cancer, if metastasis are found in the liver, it is extremely hard to treat. Okay, and it's more deadly. Now, the most invasive, the most dangerous type of cancer is melanoma. Grows actively, metastasizes actively, and it is derived from, as you can guess from the name, from the cells, melanocyte cells. The main risk factor for melanoma is the sunburn. Sunburns may increase the risk. As far as I remember, one sunburn increases the risk of developing melanoma in the affected area by 70%. Now, you have to understand, when we say increased risk, doesn't mean you're gonna get it. I want you, since you are future health professionals or current health professionals, I want you to understand the concept of risk. When somebody says, you know, smoking increases the risk of lung cancer by, I don't know, 300%, means 4 times. Means you are 4 times more likely to develop lung cancer, which means out of 100 smokers, there will be 4 times more people who develop, well, I'm not sure about the numbers, but not everybody who smokes develops lung cancer. Not everybody who doesn't never develops lung cancer. Does that make sense? But you have to remember, medicine operates with large numbers. Avoid anecdotal evidence. Do you understand the anecdotal evidence? I'll give you a great question. There is a genetic component. Absolutely. There is a genetic component to every cancer. But let's say if you spend like 3 times a week in the tanning salon, then if you are genetically resistant to melanoma, if you have certain, you know, level of maybe resistance to melanoma underlying, it may not help you anyway, because you expose yourself to so much UV light that no resistance can overcome that. Does that make sense? Now, going back to anecdotal evidence, one of my one of the examples of anecdotal evidence that I like the most, probably. At some point, every time, the oldest person dies, the new oldest person emerges, right? So at one point, the oldest person in the world was that French woman, who at the time she became the oldest person was 118, which is a respectable age. And I watched a little report, on the TV. They showed that woman. They said that she quit smoking. 116. She was 116 when she quit smoking. She started to smoke at 16. So she smoked for 100 years, for a century. Then she quit. Does that mean that if you're smoking, you're going to live to 118? No. She's just lucky. So, risk does not necessarily mean the disease, but it means, yeah, you have higher chances to develop something. So, sunburns. Smoking increases the risk of melanoma as well. Visit dermatologist regularly. Let dermatologist to see your moles. If you have a concern, immediately go and check with the doc. Because the early detection is the key to survival. Okay? Early detection, aggressive treatment, surgical removal, sometimes chemotherapy. Now we have a modern type of therapy to treat melanoma. You may have heard former US President Jimmy Carter was treated against melanoma recently. I don't remember the exact mechanism, but pretty much the idea is that your immune cells, T cells, they function, one of their functions is to recognize cancer cells, okay, and kill them. Well, cancer cells produce on their surface a little protein called, I think it's PLD1. Well, never mind the name, I don't remember correctly, but there's a protein that pretty much tells T cells, go ahead, don't touch me, I'm good. Okay? And T cells stop killing cancer cells. Well, scientists, when they figured out the functions of this protein, they developed very specific antibodies that block that protein on the surface of cancer cells. So now T cells recognize them again and start killing them. And it turns out that method, they used it to treat Jimmy Carter. That method, although of course it's freakishly expensive, was very effective. He got into full remission. So we have hope, but with cancer, it's an arms race. We develop something new, cancer strikes back. Yeah, it never ends. Does that make sense? Speaking of this, understand, like more invasive, less invasive. What is the origin of the cancer? I'm going to ask you about those three. Is that clear? We're clear on that. Those three I can ask you. Yes.
With that in mind, and since early detection is probably the best way
Yes.
of fighting any cancer, wouldn't it be in best interest if there were a cancer screening for all forms of cancer that we can screen? I guess yearly.
I love this idea. I love preventative medicine. The only problem is that US medicine is based on saving life. You can eat, you can eat like 5 pounds of Oreo every day and finish it with 4 liters of Coke and develop diabetes and heart attack and nobody cares. But once you're in ICU with a heart attack, they're going to save your life. And then you're going to go, get out of the hospital and keep your lavish lifestyle. Make sense? So, and consider the prices for various medical procedures. If the visit to the dermatologist runs at, $150 to $200 just for the screening, and then you have pancreatic cancer, which is really hard to diagnose, You have colon cancer, which requires endoscopy, which is quite literally pain in the ass. You have gastric cancer, which requires endoscopy, which is pain on the other end. You have lung cancer. Well, it's easy. X-ray. It amounts to an incredible sum of money. Does that make sense? So, all cancers, really hard. Some of them, like, know your risks. Like, if somebody has a gastric ulcer, you should, be aware of gastric cancer. If somebody has a history of colon cancer, start screening. If somebody has a history of prostate cancer, start screening early. Like men, I think it's 40 when the regular prostate screening should be done. Okay, so it's like being aware. But sometimes you just don't know. The symptoms are not there until it's too late, like with lung cancer. There was some study when they developed diagnostic test for lung cancer based on the content of your breath. There's some chemicals that cancer cells produce. I didn't really follow up on that. It would be lovely, but not feasible, unfortunately. So these three I can ask you where they originate, whether they are invasive or not, more invasive, less invasive, stuff like that. Does that make sense? Now, very extremely rare type of cancer, I'm not going to ask you about this, is called Merkel cell carcinoma. Kind of self-explanatory. Merkel cells, those sensory cells in the stratum basale, if they get infected with the special papillomavirus, they start to divide and divide and divide and give rise to Merkel cell carcinoma, which is unbelievably rare. It's like few cases in the US every year. But it's very hard to diagnose, extremely hard to treat, and the survival rate is very low. People die pretty quickly.
You said papillomavirus, so that would be cancer that's derived from HPV?
No, it's a different papillomavirus. Sorry, it's not papilloma, polyomavirus. It's different virus. It's totally different virus. Now, burns. Well, I'm not going to tell you what causes burns. There are 4 degrees. The first degree burn, which you can see here, pretty much involves only epidermis. Okay? Dermis is not affected. It's red, painful, may have edema, may not have edema. Lasts for, 3-5 days and you're fine. No treatment. No specific treatment required. Cold. That's it. Really. And then second degree burn. That's when epidermis is damaged and part of dermis as well. You can see the large second degree burn at the bottom of that palm. There's a blister filled with inflammatory exudate. It may leave the scar. Takes few weeks to heal. And one of the treatments, if large portion of the limb affected, is to elevate the limb, to let the edematous fluid drain down. Second degree burn, although it looks fairly benign on this picture, I had only one chance in my life to see a person with severe second degree burns. It was my former classmate, some idiot, was playing with, the fluid that you use to start up the fire. I forgot how to. It's lighter fluid, yeah. Playing with lighter fluid and accidentally splashed lighter fluid on her face. And it caught fire. So the entire face was burned. And it was, I knew that she had second degree burn. I was not prepared to see what I saw. It is very hard, After several weeks, it was all completely healed, nothing changed. She was just the same, no scars, nothing, but it was pretty bad. Okay. Now, third degree burn is sad because that's when the tissues die. Epidermis and dermis are dead. Parts of subcutaneous area are affected. Okay, so skin is totally lost. You can see the third degree burn here. Skin is not recovering. In third degree burn, the patient has to have a skin graft, which is a challenge by itself, because when skin transfer, usually it is taken from the back or buttocks, and when it is transferred to the affected area, while it is in the process of transfer, it has no blood supply. So skin can actually die. The transplant can die while it is being transferred. The fourth degree burn is pretty much when tissues become charcoal. In fourth degree burn, everything all the way down to the bone is affected. There is no restoration of it, usually amputation. Sometimes debridement may help if it's not like extremely severe. Skin grafts may help to cover the affected area, but the underlying tissues, as I mentioned, are going to be lost. Now, how can we calculate which percentage of the body surface is affected with the burn? For this, we use the rule of 9. Okay? And you will have to know which part of the body comprises which portion of the skin surface. So, head, okay, is 9%. You may say, wait. It is written 4.5. 4.5 up front, 4.5 in the back. Does that make sense? So if anterior aspect of your head is affected, it's 4.5%. If your entire head is burned, it's 9%. Trunk. Each aspect, anterior and posterior, 18%. So far, does that make sense? Upper limbs. Each aspect, anterior and posterior, of each limb, 4.5. So upper limbs, one is 9, both of them are 18. 4.5, 4.5, 4.5, 4.5. Total 18. Lower limbs, anterior aspect is 9, posterior aspect is 9, each limb is 18%. Okay? Now if you will add this all together, lower limbs, upper limbs, head, and trunk, all together it will give you 99%. 1% is perineum, the area between the genitalia and the anal orifice. Okay, now we have 100. Does that make sense? Severe burns is 25% or more second degree and 10% or more of third degree. It's not a lot, really. If you think about it, anterior trunk and both arms, all anterior aspects of both arms and trunk gives you 27%. And if it's second degree, it's already a severe burn. Does that make sense? So you have to know the category, well, third degree burns in the hands, face, feet, or perineum. It's also considered severe. So you have to know the percentages. I promise there's going to be a question on percentages. And you have to know the categories for severity of burns. What is the severe burn? Am I clear on that? Awesome. The main risk with the burn, actually with any burn, there are two major ones. One is dehydration. I think we talked about it. If your skin is gone, the chances for your underlying tissue to start losing water are much higher. That makes sense? Great. Yes. Wait, okay. Sunburn. Well, in the sunburn, if your skin is not blistering, it's still performing its function. Does that make sense? So what happens in the sunburn, you have inflammation of the skin. Pretty much epidermis is affected by the UV lights, but you're not getting like dead skin. In case of actual thermal burn, in the 3rd degree, skin is gone. There is no barrier between the underlying tissue and the air. So underlying tissue starts to lose water. Does that make sense? I can have 1st degree burn all over my hands. I'm not going to be dehydrated. Does that make sense? I mean, if you like really fry yourself in the sun, I cannot imagine like having that many blisters. Sunburn. But I never saw a severe sunburn, honestly. Okay? Does that make sense? You're probably not going to be dehydrated with a sunburn. Another problem with the burns is infection. That is really a big deal in the burn victims unit. When people have no skin, no functional skin, no, integrity in the skin over the tissues, microbes that are usually benign can immediately become invasive. For instance, microbe called Pseudomonas aeruginosa, you don't have to know that, but it's really, really common microbe. It's one of the main causes of infections in the burn victims. And burn units are usually very clean and very sterile, and people who work there have to change, the personal protective equipment and change it timely. They even have filtration systems so the air that gets into the burn units is sterilized. Well, not sterilized, disinfected. Does that make sense? Everything's clear about the burns? Give me 1 second. No, it is not negative pressure. No, a TB patient will be put in a negative. So what Jacques is talking about, TB patient is placed in a negative pressure room, which means air. So if that would be negative pressure room, air from the outside will get into the room and will be pumped out through the filtration system to the outside. It is done to prevent the spread of the TB to anybody outside of the room, because the filters at the exhaust, they will catch all the bacteria. People with burns, quite an opposite. They are in a positive pressure room. Air is pumped into the room, and air that goes into the room is disinfected. It is cleared of all bacteria, and it moves, out of the room, preventing anything from outside to enter. Does that make sense? Now, I want to talk to you about inflammation, injury, and repair, like fairly briefly. We're going to mention it on pause a few times in this course. But another thing, I want you to have a decent idea of what the inflammation is. It's normal response. And we're going to talk about it using skin as an example. So, when skin is damaged, okay, for instance, there is a cut. This cut essentially destroys a bunch of cells and it breaks down a lot of blood vessels. Does that make sense? Now, cells that are destroyed start to release inflammatory mediators, and white blood cells from the circulation start to migrate following the path that is pretty much outlined by inflammatory mediators. Does that make sense? Those inflammatory mediators is like sort of a tracking device, I may say so. Like the crumbs for Hansel and Gretel, you know, when they go into the forest. Am I right? Is that right, fairy tale? Okay. Like those breadcrumbs for white blood cells to get to the site of an injury. Several things happen at the same time at the site of injury. First, blood vessels start to dilate, okay? And they increase local blood flow. Second, white blood cells migrate from those blood vessels to the site of injury. Third, blood vessels become permeable, letting plasma to seep into the tissues, creating edema. So far, does that make sense? Okay? And the blood, of course, that is spilled at the site of the injury starts to clot. Now, let's talk about the roles for each of those responses. First, what is the role of white blood cells? Does anyone know? Huh? Immunity, yeah. Kill the microbes. Clean up the trash. Okay? Why blood vessels? What is the point of letting plasma out of the blood vessels into the peripheral tissue? Plasma getting out of the blood vessels into the peripheral tissue.
Because of the antibodies that's in the blood.
Antibodies are not yet there. If you have a lot of junk on the driveway, what are the ways to clean it? With a hose, right? You can just wash it off. So that plasma, when it goes into the tissue, it starts to, well, quote unquote, wash dead tissue, dead cells, pathogens from the tissue into the lymphatic system, like a sewer. Does that make sense? Why clotting? That's pretty sad. Not only this, I mean, from the small cut, yeah, you will bleed to death. But why else? Yes, but also to prevent infection. Also, some stuff is already there. Some microbes are already there. If your blood is clotted, what's going to happen to those microbes? They're stuck, yeah. So it kind of, prevents them from spreading. Does that make sense? Now, why dilation of the blood vessels? Why increased blood flow? To deliver what? Which contains which cells? White blood cells, yes. Now, think about this. We've got what? Plasma going into the tissue. What does it create? In terms of appearance.
Oh, like the white, like the, is that clear stuff?
What I mean, like if you have a cut, how does it look around the cut? Red because of the increased blood flow, swollen because of the plasma getting in there, right? So now we've got, among these, signs of inflammation, we've got swelling, we've got redness. Also, how does it feel? Painful. So we've got pain. And number 4, which hard to measure, believe me, it's a temperature. It is usually hotter than surrounding tissues. So those are 4 signs of inflammation: redness, swelling, pain, and fever. Or in Latin, if you want, I can write it down for you. It's just really neat sort of a verse. Rubor, which means redness. Color, which means warmth. Tumor, which means swelling. And dolor, which means pain. Where does the pain come from? Yes. Yes. Mostly from swelling. Also, some of the inflammatory chemicals, they directly activate sensory neurons, sensory nerves, and directly send the pain signals. Does that make sense? Now, I've got all that crap going on, you know. Now, what happens next? Next, you need to repair the cut. So inside of the clot, the red blood cells, dead white blood cells, platelets, slowly destroyed and replaced by so-called granulation tissue, which is produced, by fibroblasts. Fibroblasts also produce collagen fibers, and collagen fibers start to close the gap that is created by the cut. You can see the regenerating tissue. Okay? Macrophages still keep going and, destroying the bad cells, the dead cells, the bacteria. And eventually, the epithelial cells proliferate, migrate on top of the granulation tissue and cover it with an epithelial layer. Okay? And what you end up with is the scar tissue, which is connective tissue, okay, right here, overlaid by the epithelium, regrown epithelium. If this is skin, you're fine. Make sense? Think about it. You had connective tissue in the dermis. You had epithelial tissue in the epidermis. Made a cut. Connective tissue in the dermis is back again. Epithelium is regrown. Everything's good? Seriously, everything's good. You're fine. However, and if you think about it, this is inflammation. Inflammation is because of injury. And the result of inflammation, the ultimate outcome of inflammation, is the repair. Does that make sense? Please understand those steps, those 4 signs of inflammation, the role for connective tissue forming the scar tissue, epithelium growing over that, okay? Very basic stuff, collagen fibers stitching the ends of the gap. But here's some food for thought. What if you have some sort of injury, like myocardial infarction, dead tissue in the heart? That's injury, right? What's going to be the response to injury? Inflammation. What is the ultimate outcome of inflammatory process? To heal, yes, repair. Now, the bummer with the heart is that cells, muscle cells of the heart, they don't divide. If they're dead, they're gone. What's going to replace them? Which consists of what tissue? Can connective tissue contract? So your heart becomes less of a muscle. Somebody has second myocardial infarction, even less of a muscle. And then less of a muscle. And then less of a muscle. Does that make sense? What if somebody drinks excessively? What happens to the cells of the liver? They die, yes. When they die, is that an injury? Yes. Does that cause inflammation? What's going to be the outcome of inflammation? Repair, which is done by connective tissue. So instead of a liver, you have a bunch of connective tissue. That is called cirrhosis. So you can see that inflammation is a normal response to the injury. The problem is that in some tissues, the repair isn't done right. It's like, replacing a drywall with a piece of paper. I mean, Technically you have no gap, but it's a lousy wall. Does that make sense? So it's sort of a food for thought here. So we're done with this.